When we kind of think through all of that, there are a number of different experiences that we're all bringing to the table when we think about the products and services that we design. And there's certainly a lot of intersectionality that we all live within in terms of who we are. Uh, I'm certainly an emergency doc, but I'm a mom, I'm a daughter, I'm a wife. I'm also, I think about innovation and design for a big academic institution. At one point, I was a startup founder. My family's from Jamaica, so I'm an immigrant, but I grew up in the States. And even across all these true statements, I have two that are true and five that are false. And so even throughout that kind of constant recognition that throughout my life, I've been exposed to multiple perspectives and gratefully and continue to be exposed to a lot of perspectives. But even with all those perspectives of my own that I bring to the table, there's still a certain amount of bias that I bring into the design process. And that bias is something that I continuously have to challenge, continuously challenge to iterate and innovate and make better things for people fundamentally. When you think about the things that we've created across different industries, you think about motor vehicle safety, there are assumptions that we make in the design process. You think about how you situate yourself in a car, where the headrest sits, where the seatbelt comes across your body. As an emergency doc, I see a lot of people who come into my department, who've been in motor vehicle accidents. And, it's something that I never put too much thought to, but, there's very clear evidence out there that says that women are 47% more likely to suffer injuries after a motor vehicle accident compared to men. And that's even after you adjust for the things you think you should adjust for. I mean, you adjust for weight, you adjust for height. And really what it comes down to are these elements of design that weren't considered, that it wasn't just weight and height. But there's also this difference in female neck strength and musculature and the way you actually sit within the seat and where your head restraints are positioned. And this has actually become an opportunity for partnership, right? Partnership to kind of think through, how those different elements we can actually design for in the manufacturing process and think about kind of when we have those high activation traumas, how we ingest that kind of data at the individual level to design better products and services for what is a fundamentally diverse population. And, that extends as well into healthcare. Fairly early on in the pandemic, as a healthcare system, we were expecting large numbers of people showing up and not knowing how to fundamentally triage them. And one of the ways we triage is kind of getting very close and personal and getting some vital signs, getting a temperature, getting your oxygen levels, things like that. And we're fortunate to kind of work with some of our colleagues in a big academic center to kind of think through how do we leverage facial recognition software in AI algorithms to really kind of think through how we can predict who's got a temperature, who has low oxygen levels, who should we put in different spaces to kind of optimize safety, but also maybe use less of our personal protective equipment, kind of be able to give that amount of distance so that we're actually kind of treating patients in appropriate zones where we're thinking through, again, how we best provide care, but also protect those who might not yet be infected with COVID. Right. And as we kind of came through with this low prototype solution, one of the things we acknowledged is that our training data set had some diversity, but it didn't have enough diversity. Right. And then we were using facial recognition software, which was very sensitive to skin tone. And so that aspect of low oxygen levels and recognizing blueness around the lips was much harder on darker skin tones. So we made the algorithm publicly available. We published it. And a few months later, I was fortunate to see one of our big industry partners come back to me and say, hey, we've got this great new tool. And this is a tool that is going to allow you to triage for vital signs. It's something that you can use alongside your virtual care. You can use it in person. It's really incredible. And it sounded a lot like what we had done before. So the first question that I asked out of my mouth was, tell me about the training data set. Tell me about what it looks like. How did it respond across populations, across different skin tones? What did the validation of it look like? And there were no answers, right? No one in the room knew the answer to the question. First red flag. A few weeks later, I connected back with the same partners, and we were talking about something else. But I said, "Hey, whatever happened, with that triage?" So we were super interested in it, wanted to know more. And it turns out that they just never tested for it. They never thought of it. And part of it is that piece of experience of, when you're thinking through what you're building your technology on, you have to be intentional about making sure that it serves diverse populations.